found 6 trials that could directly address this question. We integrated those into a systematic review and meta-analysis, and overall, for the primary outcome of cardiovascular death, MI, or stroke, the traditional MACE endpoint, there was a 22% statistically significant risk reduction for that outcome, and there was no heterogeneity, so a very consistent signal across the 6 trials. And for the first time seen, there was a significant reduction in the cardiovascular death alone endpoint, with again a 15% relative risk reduction with extended dual antiplatelet therapy. In appropriately selected patients who are within 1 to 3 years, on average 2 years from a myocardial infarction, extending dual antiplatelet therapy with one of several potential antiplatelet regimens seems to have a significant benefit for cardiovascular endpoints. Of course, in that context, there is an increased risk of bleeding, but no increase in fatal bleeding or intracranial hemorrhage. And so I think in the appropriately selected patients, it would be the appropriate thing to do to continue therapy or to extend therapy in those patients.
Optidual is a French trial in which 1,385 patients were randomized a year after DES implantation either to stop dual antiplatelet therapy or to continue it for an additional 36 months.
In fact, we did not reach a statistical significance. Extended DAPT had a better outcome than aspirin alone, but the study was not powered enough to reach the statistical significance. However, our results are in agreement with the findings of the DAPT trial, showing the value of prolonging DAPT from 2 to 3 years after PCI, after DES placement.
We conducted the analysis of a large multi-center worldwide registry called Clarify. The general idea of the registry is to collect data on the treatment and outcome in outpatients with coronary artery disease that are stable. This is something which is not very well explored. We tried to find out whether any differences in outcome exist between patients treated primarily by non-cardiologists and cardiologists. Overall, there was about 20% decrease in primary endpoint in patients who were cared for by cardiologists. However, it's most probably that this was due to the treatment population composition rather than to the quality of care provided by both groups.
The platform study included 584 patients with chest pain who were evaluated using either FFRCT or conventional testing to see if FFRCT could reduce the rate of invasive coronary angiography that showed no obstructive CAD.
We were aiming to test the effectiveness of a CT, non-invasive fractional flow reserve guided care compared to usual care in patients with suspected coronary artery disease. And what we found was that among patients with a planned invasive catheterization, there was a dramatic reduction in the rate of not finding no obstructive disease at angiography from 73% to 12%, with no differences in adverse events or radiation exposure.